Good afternoon, everyone. Welcome to this session of CAHO Diagnostic Division. I'm sure all of you who have joined know what CAHO is. It is the consortium of accredited healthcare organizations. And what we work towards is safer patient care, strengthening quality, promoting accreditation, sharing best practices, and creating benchmarks. And we do this, we have been lucky that our parent organization decided that the diagnostic divisions needed some more attention. And they established the diagnostic division, and we are all members of that. I have many co-workers. And what we have been doing over the past 2 years is we have been conducting several webinars on almost a weekly basis for the last 2 years, called the Continuing Diagnostic Education Series. We have talked about COVID-19, about body fluids and their interpretation, about radiation safety, about epigenetics, about breast cancer, about risk management, about pregnancy and screening, about cervical cytology and HPV, about harmonization of analytes, about current challenges and latest guidelines, lipid profile testing, and many more. These are just a few listed here. And the whole aim is to bring every one of our healthcare activities, or rather all our healthcare professionals, to a level where they can look after the patient in the best possible manner. And that is what we are striving towards. Risk management is a very important part of it. And so we have training programs in that. We have regional conclaves also, and we have one coming up in Jabalpur on 25th and 26th February. And that is the way we just go on and on, trying to disseminate as much knowledge as we can, to gather it also, to improve ourselves and to help improve everyone else. We now also we have an upcoming annual conference at Hyderabad. The laboratory section of CAHO is conducting it on 14th April, and the main CAHO has it on 15th and 16th April. It is at Hotel Abode by Sri Venkateshwara. And the whole, we are also having several pre-conference workshops there on the 13th of April. And I think that most of you, this probably will be the Good Friday weekend, so people will be able to attend it. These are weekends which they can take time off work and enjoy themselves. And now I would like to hand over to the moderator of the session. She is the Chief Officer and Infection Control Officer, as well as consultant clinical microbiologist at Caritas Hospital and Institute of Health Sciences at Kottayam, Kerala. Over to you.
Thank you, Seema ma'am, for the introduction, for the kind introduction, and for introducing our CDE series and CAHO. So my job today is to actually introduce our moderator and our organizer for today. So our organizer is Dr. Rajiv Matthew. Dr. Rajiv Matthew is a mainstream medical biochemist. He is currently working as the Assistant Director Manager for the Laboratory Quality and Risk at Believers Church Medical College Hospital, Tiruvalla. He has done his MSc in Medical Biochemistry from CMC Vellore, and later on his PhD in Medical Biochemistry from Yanapaya University. So it's with a lot of pleasure that I introduce Dr. Rajiv Matthew, our organizer. And moving on, our moderator for the day would be Dr. Seema Bhargava ma'am. She, in addition to being the chairperson of the diagnostic division of CAHO, Madam is again a mainstream clinical biochemist. She is an MBBS, DNB, and PhD honor bearer who has been awarded FRC PAT as well. She has worked in the Department of Clinical Biochemistry at SGRH New Delhi since 1992. And she has a lot of research on homocysteine, and her research continues to focus on identification of clinically relevant biochemical markers and their application in various areas of medicine like neurology, Alzheimer's, cardiovascular disease, sepsis, immunology, diabetes, and special reference to micronutrients. She's a recipient of several institutional, national, and international awards, and a lot of publications, over 50 in national and international index journals. And she has authored a book titled Clinical Applications of Homocysteine, published by Springer International in 2018. So welcome, ma'am, once again as the moderator of today's session. And the next job that has been entitled to me is the introduction of our first speaker, Dr. Kannan Vaidyanathan. He is a professor and head of Department of Biochemistry, Believers Church Medical College, Tiruvalla. And he is an MBBS, MD mainstream biochemist with a postdoctoral fellowship in microbiology and cell biology from Indian Institute of Science, Bangalore. He's a research-oriented person with more than 85 publications, including 25 in PubMed Index journals. And he has co-authored 3 textbooks in biochemistry, which are being used around the nation by enthusiastic postgraduates and undergraduates. So I extend my heartfelt welcome to Dr. Kannan Vaidyanathan for delivering the session, and I request Dr. Seema ma'am to moderate the session.
Welcome, Dr. Kannan. We meet once again.
Yeah, thank you very much for the kind introduction, Dr. Deepti, and thank you, Seema madam, for giving me this opportunity. Dr. Seema madam, Dr. Rajiv, and the entire team at CAHO for giving me this opportunity to speak on this topic, cardiac biomarkers. Cardiac biomarkers, which I'll be talking for the next 30 or 35 minutes or something. Now, first of all, what is a biomarker? Now, biomarker essentially is any substance which is used to indicate the presence of it's a diagnostic indicator for a medical condition, essentially. So we generally, since we are dealing with medical diagnostic, we use the biomarker for diagnostic, but it can also be any other biological thing also. But essentially in the laboratory, we use it for diagnostic of medical condition. It is in shorter, in just more simpler terms, it can be used as an indicator for any particular disease. For example, it could be used for liver diseases, renal diseases, and in this case, it is used for cardiac biomarker. Now, when do we test cardiac biomarkers? Now, it can be used in many conditions, many clinical conditions, including any kind of chest pain which a patient is having, unstable angina, or whenever there is suspicious ECG changes, or any history in the patient suggestive of myocardial infarction, usually acute the presentation, or sometimes even chronic presentation, following surgical coronary revascularization, or patients who have hypertension, dyspnea, etc. These are some of the clinical conditions where usually cardiac biomarkers are tested. Now, there are lots of cardiac biomarkers in the market currently available. Now, one way to simplify this is to classify the cardiac biomarkers. Now, I have just given a simple way of classifying the cardiac biomarkers. The first category are markers of myocardial infarction. Now, serial estimation of cardiac biomarkers is done to assess the progress of the ischemic progress. Now, in fact, there is no single marker which can be used to successfully either identify or exclude acute MI in the first 6 hours, which is the most important time period. But however, a combination of many of these biomarkers can be used in this time period, the first 6 hours, which is also the most crucial as far as the prognostic features are concerned, or the treatment is concerned, etc. Now, these include the cardiac troponins. Now, we have 3 cardiac troponins of these, but 2 of them, cardiac troponin T and cardiac troponin I, are widely used as myocardial infarction markers. Then the second second one is the high sensitivity troponin, HS of the high sensitivity, TNT and TNI. Then you have the creatine kinase isoenzyme and the CKMB isoenzyme. Now, these are the most important among the biomarkers which can be used for myocardial infarction markers. Now, in addition, in some cases, we'll just talk briefly about myoglobin. And in the earlier times, we also use lactate dehydrogenase, aspartate aminotransfer, LDH and AST are no longer used in the current context. It's just of historical importance. Now, the second category of cardiac biomarkers are the markers for risk prediction. Now, how does this come into place is because many cardiac disorders can be treated or if detected early, or if the risk is detected early. So you have markers, the classical markers like cholesterol, total cholesterol, LDL and HDL cholesterol, the apolipoproteins, ApoB100, ApoA1, LPA, the lipoprotein A, serum triglyceride, the plasma high sensitivity CRP, and even in the some other markers like the HbA1c in diabetes mellitus, serum homocysteine, which is now Seema madam must be interested in that now. She has done lots of work. I know about that. So now, on the recent years, serum homocysteine is not used, but then you have other markers like lipoprotein associated phospholipase A2, which is coming up. These are some of the markers for risk prediction in cardiac diseases. And then you have the third category, which are the markers of myocardial stress. And this includes the brain natriuretic peptide and the NT-proBNP, and BNP and proBNP. I'll talk more details about BNP and NT-proBNP later on. But until recently, it was considered a reliable marker of ventricular function. But now, of recent, there are some controversies, and IFCC is also addressing that. Then you also have some other markers which are not very commonly used, but just to complete the list, like adrenomedulin, copeptin. I won't be talking too much details about those things. So these are some of the important biomarkers classification-wise for the cardiac diseases. Now, of these, again, the most important would be the first two categories, and why I'm not mentioning third category I'm not mentioning. Just I'll keep it the suspense for some more time. So now that was just a classification wise. Now, in addition, if you look at the literature, if you just search in the internet for cardiac markers, you come across so many molecules which are used as cardiac markers, like markers of inflammation, markers of necrosis, ischemia, genetic markers, hemodynamic stress, platelet function markers, hemostasis markers, etc. Now, these are all important in their own respects, but many of them, the problem is that they are not actually found clinical utility as far as the actual patient benefit. These are used as research tools, and in many papers have been published, potential use, potentially important, like that. Many papers have been published, but however, in the actual clinical scenario, day-to-day clinical scenario, many of these have not found much utility or limited utility. I won't say non-utility, but limited utility. Of course, this can be maybe more work is needed before they can be brought into the market, or in the future years, many of these might be used in more utility. So I come to each of these markers not in too much detail because of the lack of time, because we are just having a snapshot picture of some of these important markers. So first of all, the cardiac troponins. Now, the troponin complex consists of three components, as I mentioned in the introduction. These are troponin C, which is calcium binding, troponin I, the actomyosin ATPase inhibitory element binding, and the troponin T, which is a tropomyosin binding element. So this is how the on the myofibril, this is how the troponins may be found to be located. So troponins of these, two of these troponins are more commonly used in the cardiac as cardiac markers. So first of that is the troponin I. Now this is released into the blood within 4 hours after the onset of myocardial ischemia. So this is one of the earlier biochemical markers for cardiac marker, and CTI is used as a useful marker at any time interval after cardiac attack. It can be used at any time interval after 4 hours, and then it can be utilized. And the advantage for troponin I is that it is not increase in other muscular injury. So only for, it's quite specific for myocardial injury and has a normal level of nanogram per ml, 1 nanogram per ml. And the TNI levels more than 1.5 nanogram per milliliter is suggestive of myocardial infarction. And the other important thing is that a negative cardiac troponin test after 12 hours. So I said that it starts to elevate within 4 hours, and after 12 hours, if it is still negative, it can be used to exclude acute myocardial infarction in any patient with chest pain. And the most important point is that it is not increase in muscle injury. So 4 hours to 12 hours, in that time period, it can be very effectively used, but before 4 hours, again, the troponin I is not much important. And troponin T is also increased within 4 hours of myocardial infarction. The normal level is less than 0.01 microgram per ml, and in myocardial infarction, it can increase to 3 times more than 0.03 microgram per ml. And the level of troponin will generally reflect the infarct size. That is, the more higher the increase in troponin T, the higher will be the size of the infarct. And generally speaking, as a general rule, the troponins can be considered to be more sensitive than the second marker, which I'll be talking about, that is CKMB, to detect particularly microinfarctions. Small sizes of infarctions are more sensitive. So troponin generally is more sensitive marker. That's what is generally believed for myocardial infarction. Now, serial estimations of cardiac troponins are important. So that is, they're very commonly done in a patient reporting with symptoms of myocardial infarction or chest pain in the emergency clinic. So you need to do serial estimations, and of course that will reflect on the cost to the patient as well. Now, and even without ECG changes, the present day protocol is to assay the troponins immediately on reaching the emergency room. So even when the patient comes, even the first thing would be to take the blood sample, because anyway it is going to take some time. But even though it is elevating only at 4 hours, it is good to have a basal level before that. At the time, at the earliest, if you can have the troponin level, that would be good. And after that, at 3 hours, 6 hours, and 12 hours, usually serial estimations are done. An increasing blood value of troponin is almost confirmative of myocardial infarction. Rather than any absolute value of troponin, the increasing blood value is more indicative of myocardial infarction. Of course, the high values also indicate troponin, myocardial infarction, but a value which is increasing is better than just a single value. That is why serial estimations are done. And troponin estimation could detect the MI even before the ECG changes are noticed in certain extents. Now, the other marker which is used is the high sensitivity cardiac troponin, troponin T as well as troponin I. And this is actually higher sensitivity. It's an assay which has been developed with a higher sensitivity than even the troponin T or troponin I. And these are improving the identification of patients with acute myocardial infarction in the first 3 hours following the onset of symptoms. And here also, it is more expensive, but still here also 2 measurements of high sensitive troponins are needed for the assessment of patient with chest pain. So at least 2 are needed. And the first measurement should be as early as possible at presentation. And the second sample should be measured 3 hours later. And a rise about 20 to 100% is equivocal and needs further evaluation, whereas a greater than 100% rise is almost consistent with myocardial infarction. And high sensitivity CT and T values are increasing with increasing age, especially at ages more than 60 years, also especially probably because of the higher infarct size in these patients and also in patients with impaired renal function. So that's about the troponins and high sensitivity troponin. And the next marker which we will discuss is creatine kinase. Now, any biochemist is very familiar with creatine kinase, which is the enzyme which is involved in ATP metabolism, the creatine kinase, creatine phosphate metabolism. and ATP is converted to ADP in this reaction. The normal value is about 15 to 100 units per liter for males and 10 to 80 units per liter for females. Now, CK will start to rise about 3 to 6 hours of infarction, and the advantage is to early detection of cases even when ECG changes are ambiguous. So that's also the advantage. So like the troponin, which is setting in about 4 hours, so CK also tends to elevate about 3 to 6 hours after infarction. So the CK-MB test is very commonly used in myocardial infarction. Now the MB is the ISO, as you all know probably, it's the isoenzyme of CK which is elevated specifically in cardiac conditions. We'll talk more about CK-MB. Now these are the three major isoenzymes of the creatine kinase: the CK-MM, the CK-MB, and the CK-BB. Now, the CK-MM is found in the skeletal muscle, and it is a major share of the creatine kinase of the total share. It's about 80%. The CK-MB is intermediate, and it is almost specific for cardiac, and it's about roughly about 5% in the normal blood. And CK-BB is a brain isoform, and it has minor percentage in blood normally. So that these are the three major isoenzymes of the creatine kinase: CK-MM, CK-MB, and CK-BB. Now, CK-MB is the cardiac isoform, even though it forms only 5% of the mean in the blood. However, it is very important because it is cardiac specific, and therefore it is important in the myocardial infarction. Now, the serum level of CK is elevated in muscular dystrophy. So, especially the CK-MM isoenzyme, it could be elevated 500 to 1,500 international units per liter. And it can be elevated in crush injuries, fractures, as well as acute cardiovascular accidents. And the estimation of total CK is employed in muscular dystrophies, whereas the MB isoenzyme is almost specific for myocardial infarction. Now, structurally speaking, it's a dimer. That is why they have the three forms: MM, BB, and MB. And the skeletal muscles express the CK-MM about 98%, whereas very minor forms only found in the CK-MB from the skeletal muscle. So this diagram shows the time course of elevation of cardiac troponins and CK-MB. So you can see the peak elevation of is more in the case of CK, is almost like coming fast within 3 hours or 4 hours in the case of both CK-MB as well as troponins. But maybe the more elevation and more will be seen in CK-MB. However, the troponins are considered to be more sensitive and specific for the cardiac conditions. Now, coming to the next marker, this is myoglobin. Now, myoglobin is raised after myocardial infarction, but the problem is that it is not specific, as it is also indicated following other muscular injuries. And it has the advantage of responding very rapidly, rising and falling even earlier than CK-MB or troponin. And the myoglobin is released as early as 1 to 2 hours after the onset of symptoms following acute myocardial infarction. And that probably is the major advantage of myoglobin. However, it is not very specific because it can also be elevated in muscular injuries, but it is very sensitive for acute myocardial infarction within the first few hours after presentation, whereas the other markers may be getting elevated 3 to 6 hours only. And the other advantage of myoglobin is that a negative value of myoglobin will rule out infarction, and therefore it is useful in the early hours of chest pain too. And the last marker for myocardial infarction is lactate dehydrogenase. This was used in the earlier days. However, it is highly non-specific and therefore rarely used in the recent times, and therefore I'll not be talking more details about lactate dehydrogenase. Now, coming to the risk markers, the first one I'll be discussing is a natriuretic peptide. Now, you have two types of natriuretic peptides. One is the atrial natriuretic peptide, or ANP, and the second one is a brain natriuretic peptide, BNP. Now, ANP is produced primarily in the cardiac atria, whereas BNP is present in the brain, human brain, but it is more present in the cardiac ventricle, and therefore patients with congestive cardiac failure have high concentrations of both these natriuretic peptides, ANP and BNP. But BNP probably became more popular than ANP for this congestive heart failure. Now, concentrations are considered to be correlated with the extent of ventricular dysfunction, and high concentration of BNP predicts long-term survival. So it is supposed to have a good, it was supposed to have a good prognostic value as far as the survival is concerned. Now, the BNP test helps to differentiate heart failure or obstructive lung disease as a cause for breathlessness. So COPD or worsening of the cor pulmonale can be ruled out with increasing BNP, and this can be differentiated from heart failure. That is another advantage of having the BNP test. So this just, I'm not going into too much detail because of lack of time, but this is how the BNP molecule is formed. First, you have the activation of the BNP gene, and then you have the pre-pro-BNP, which is then cleaved to produce a pro-BNP. And from there, you have the active BNP and the NT-pro-BNP, the N-terminal pro-BNP. The NT-pro-BNP is, the N-terminal is biologically inactive, whereas the BNP is the active metabolite, and it has multiple functions, including the effect on the renin-angiotensin system, causing natriuresis and diuresis. And as you can see, that has multiple roles, and this just okay, this is just summarizing some of the other markers which can also be used in cardiac biomarkers in addition to proBNP, which has also been used earlier, described to earlier. Now, this is what I would like to highlight because even today, I just came across a clinical, a friend of mine was just discussing. In fact, today morning, she was sharing the reports from her father who was having congestive heart failure, and he was probably doing, he was a diabetic and hypertensive, but otherwise he didn't have any symptoms of cardiac failure, but probably he was having breathlessness, but some of the other biomarkers were normal, but however the brain natriuretic peptides and proBNP were elevated in this patient. Now, the latest IFCC recommendation suggests that care should be taken before implementation of BNP and proBNP into routine clinical practice. Now, there are many factors to be considered, including standardization, the types of assays used, including harmonization, the age-stratified cutoffs, etc. And IFCC suggests that further studies are needed before these promising markers are used regularly in clinical practice. However, even though IFCC has given these guidelines probably in the last couple of years, even today, the BNP and proBNP are widely used in clinical practice. So probably many clinicians are still ordering it, but probably this message needs to be conveyed because, and maybe even if the BNP and proBNP are used, again, the IFCC also suggests that serial estimations are also important before they can be used. So it's important to take note of these recommendations before the BNP and proBNP are used in regular practice. So this will just summarize the cardiac biomarkers. Now, the troponins are the preferred markers, which sets in about 4 to 10 hours, peaks in 18 to 24 hours, and it can be elevated up to 8 to 14 days after the infarction. Now, CKMB is a useful marker. It tends to get elevated almost a similar time, 3 to 6 hours. The peak is again 18 to 24 hours, and the duration is 36 to 48 hours. And the classification, the remark is given as it's a useful marker. Now, myoglobin is non-specific, but however, it can be used as an early marker, and LDH is not used nowadays. And now there are also various other markers which I just mentioned. I showed you 2 slides where so many markers have been shown. Now, many of these are not routinely used, but however, they are there for research purpose. Now the next one are the markers. I'll go through these quickly. The markers for the risk factors for cardiovascular disease. So many of these are very well known. So I'll be quickly going through these. These include cigarette smoking, of course, it's not a cardiac, it's not a biomarker, but then you had high total cholesterol, high HDL, low HDL cholesterol, high LDL cholesterol, a high cholesterol, a fat cholesterol diet, left ventricular hypertrophy, thrombogenic factors, which are all modifiable risk factors proven to lower the cardiovascular disease risk. And then you have the modifiable risk factors and interventions likely to lower the CAD risk, like lipoprotein A, and then clinical conditions like diabetes mellitus, hypertension, physical inactivity, obesity, and markers again like serum triglycerides, serum homocysteine, which I said is controversial, and many clinicians don't use it for cardiac conditions anymore for homocysteine, and increase high sensitivity CRP, stress, etc. And non-modifiable risk factors may also be just mentioned like family history, male gender, age, etc. Now, quickly going to that serum cholesterol, the normal persons, it is about 150 to 200, and preferably below 180 values. About around 220 milligram will have a moderate risk, and values about 240 will need active treatment. That's what the recommendations say. LDL cholesterol, the blood levels under 130 are desirable. 130 to 159 are borderline, and above 160 carries a definite risk, and it is considered as a bad cholesterol. HDL cholesterol above 60 milligram protects against heart disease, and below 40 increases the risk, and it is considered a good cholesterol. Now, mind you, these are in a normal person, whereas as you all know, these values will change if you have a cardiac disease. Like in cardiac disease, even below 100 or something is recommended for LDL cholesterol. Lipoprotein A, LPA, the levels more than 30 milligram per deciliter increases the risk 3 times. And when the increased LPA is associated with increased LDL, that is essentially the apolipoprotein, the risk is increased 6 times. And serum triglycerides, again, for a normal person, it is about 50 to 150, and above 150 milligram is supposed to be a risk factor. And another, there are various indices like combinations of these which are being used, and in many laboratories give these indices also. For example, you have the non-HDL cholesterol or atherogenic cholesterol, which is a combination of LDL, VLDL, and even IDL and LPA. And it is suggested that non-HDL cholesterol 100 to 130 milligram per deciliter or less is very little risk. 130 to 160 is borderline risk. 160 to 190 is high risk, and above 190 is very high risk. So these are the major risk factors. So to summarize the risk factors, a low risk is considered to be total cholesterol below 200, LDL below 130, HDL above 60, and triglyceride below 150. Borderline risk is cholesterol, total cholesterol 200 to 240, LDL cholesterol 130 to 160, HDL cholesterol 35 to 60, and triglycerides about 200 to 400. And very high risk or high risk is total cholesterol about 240, LDL above 160, low HDL below 35, and very high triglyceride above 400. So this is one way of summarizing the cholesterol. Again, I emphasize this is for a normal patient, and for already a person with cardiac disease, these values will change. Now, just a few words about some of the other markers which are coming up for risk prediction. One of them is the high sensitivity CRP or HSCRP. This is used to predict a healthy person's risk of cardiovascular disease, and this has a 1.5 to 4 times the risk of having a heart disease, HSCRP level. So low risk is less than 1 milligram per deciliter. Average risk is 1 to 3, and high risk is considered to be about 3 milligram per liter. So high levels are having 1.5 to 4 times the risk of these heart diseases. And now it should be remembered that atherosclerosis is also an inflammatory process, and a low level of long-term inflammation produces only a small amount of CRP, and therefore the test requires higher sensitivity than specific tests. And that is why the high sensitivity CRP is used for cardiac disease and not the normal CRP, which might not be indicative of cardiac disease. The high sensitivity CRP is used as an indicator for cardiac disease. Now, the HSCRP is a marker of inflammation, and it's important that any person having the test should be apparently healthy. Otherwise, it may not have much value in predicting the risk. For example, tissue injuries, infections, arthritis, general inflammation can raise the amount of CRP and therefore also elevate the HSCRP and therefore give a falsely elevated estimate of risk. So it should be rather in the in the normal state of health before they can be used as a marker. Now, homocysteine was used in the earlier years. A plasma homocysteine above 15 microgram will increase the risk of cardiac coronary artery disease as well as stroke. Now, even today, it is used to some extent in stroke, but in cardiac disease, most cardiologists, I don't know how many cardiologists are still favoring homocysteine. Very few only are favoring the use of homocysteine for cardiovascular diseases. And administration of pyridoxine, vitamin B12, and folic acid may lower the homocysteine level. And then other risk factors include obesity and sedentary lifestyle. And this marker is the lipoprotein associated phospholipase A2, LPPLA2. It is also known as the platelet activating factor acetyl hydrolase or PAFAH, and it is an enzyme which is produced by the inflammatory cells. It is expressed in the diseased vessel and is considered as a marker for plate instability. And unlike HSCRP, the LPPLA2 test is specific and it is not affected by conditions other than cardiovascular disease. So even when there is general inflammation such as arthritis, now this marker may be used and therefore it has a greater advantage than HSCRP. But it is relatively new test and the clinical usefulness is to be established still and is not used as a diagnostic of cardiovascular heart disease or ischemic stroke, but is just as an risk indicator only. It is not cannot be used as a disease indicator, but it's just a risk indicator. You have various other candidate markers like ischemia modified albumin, adrenomedulin, which is a vasodilator peptide, and copeptin, also known as a CT-pro-AVP, which is synthesized in the paraventricular neurons of the hypothalamus. Now, many of these are potential markers or candidate markers, but still the clinical utility has not yet been proven for many of these markers. Now, this particular marker has been a major breakthrough in cardiac testing as far as some reports say, the IMA. Now, the serum albumin has a capacity to bind heavy metals like cobalt and copper, and this binding capacity is reduced when albumin is damaged, and this test is used as the ischemia modified albumin assay. So it is suggested that when there is ischemia, the albumin levels are altered, and therefore this particular marker, the ischemia modified albumin assay, has been used as a major breakthrough for cardiac testing, but still again it is only in the experimental stages. The IMA test is very easy to perform and can serve as a point of care test in cardiac ICU, so it can be used as a POCT test in the ICU setting. And generally it has, on a research setting, it has shown a very good correlation with other cardiac markers and is supposed to be cost effective, and a high predictive value of negative IMA test is highly useful and can be used as a guide to shift the patient out of the ICU and saving precious resources. So that is the advantage of the IMA test. One, it is easy to perform and can be used as a POCT test in the cardiac ICUs and has a good correlation. So finally, to summarize, what's my take-home message? Now we have summarized some of the available cardiac markers like the cardiac troponin, CKMB. We also discussed about myoglobin, briefly about the LDH and the other risk markers, including the lipid profile and the other markers. Now, cardiac troponins and CKMB are widely used as myocardial infarction markers, and the risk prediction markers help the prevention of CAD to varying extent, of course, depending upon how we utilize the data which is coming out of the how the individual users it, like the high cholesterol, the triglycerides, the HDL and LDL level, the apolipoproteins, etc. Now, strictly speaking, the role of BNP and pro-BNP is controversial, and the IFCC does not recommend the regular use of BNP and pro-BNP in the clinical practice, even though it is continued to be used. And then we also discuss some of the new promising markers which are being introduced into the market. And some of these may be coming into the actual clinical utility in later years. And of course, with more research being carried out in this direction, probably we'll have more better markers for the cardiac conditions coming up in the future. So once again, thank you very much for a patient listening, and I'll be happy to take any questions.
So Dipti, can you check the chat box, Dr. Seema, because I have few questions, but first let us look at the chat box.
While Dipti checks the chat box, I'd like to thank Dr. Kannan for so clearly identifying the biomarkers of cardiac disease, those that have been proven to be useful, clinically useful, those that have not been proven to be clinically useful, and those that are still in the research stage. Thank you so much, Dr. Kannan. Dipti, can you see the chat box? I cannot see it.
Shall I?
Yeah, sure.
Yeah, Dr. Raju, you can go ahead.
Yeah. Thank you, sir. That was a very clear picture on cardiac markers, sir. So there was a question raised by Dr. Varsha Birla. And the first question is, among the troponin T and I, which is more sensitive and specific?
In troponin T and I.
Yes, sir.
I think that troponin I is more specific or more utilized. I think both.
I believe that both are of equal sensitivity and specificity.
Probably the. I think both are used almost concurrently in the most of the conditions. Maybe research-wise, I don't know. Maybe troponin I has slightly more sensitive. I'm not sure about that. I think.
Sir, she also continues. Can you also comment on the POCTs currently used in this area?
That's a good question. Now, POCT is actually right now. I don't think it is routinely used. Like for example, I talked about the IMA marker, IMA test. Now, it is not. It is not regularly used in clinical practice, but it's a potential marker. These would come as a potential markers. Now, even now, I think for myocardial infarction, the CKMB and troponins are more utilized for this actual clinical practice. Probably in the coming years, more utility of these other markers might come. Just a second.
Okay.
Use the fan volume just for.
Dr. Seema, can I say something? I'm Dr. Shanti speaking.
Yes, ma'am, please.
Actually, regarding TROP-T and TROP-I, they are of equal importance. But if you actually see the numerical values, you get more significant evidence in TROP-I is my personal experience. The other thing is when you review TROP-T, you have to keep the renal impairment in mind. There are no actual cutoffs that are there for creatinine that can say at this level of creatinine, definitely troponin will be high, TROP-T exclusively. So the TROP-T is greatly influenced by renal impairment, whereas TROP-I does not have that. So that is why in many ways TROP-I is considered to be more practical when you use it clinically.
Yeah, and the other utility of
Thank you, Dr. Shanti, for clarifying that. Thank you.
The utility of TROP-T comes also when you are considering the size of the infarct. If you want to detect a higher size infarct, the TROP-T has more significance, whereas TROP-I probably, as Dr. Shanti was telling, probably TROP-I is among the two, but both are essentially both commonly used together.
Sir,
Dr. Shanti, would you like to comment on POCTs also?
Excuse me, would I like to comment on POCTs?
Yes.
I do not practice POCTs, but in smaller nursing homes and smaller size hospital, yes, as a first run, it is useful because then you have time also to take action and get the quantitative assay done. But the quantitative assay by the laboratory platforms is absolutely essential. To go only by the POCT, especially since we do not have so many standards or IQCs to prove in our country at the moment, I think we have to be a little cautious when you use POCT.
Thank you. Thank you. I agree with you totally. And the Dr. Kannan too. He said the same.
Dr. Kannan, there is one more question that is raised by Dr. Long Kumar. He's asking that, as you know, the reference range of HDL cholesterol is listed as between 40 and 60. He's asking whether the HDL cholesterol above 100, is it considered good or bad?
Well, of course, too much high is also not recommended. You don't get that much high HDL. Generally, about 60 is the considered to be good, because you're anyway going to have a total cholesterol also high. 60 is generally considered.
In that question, I would like to say that we do see very high levels of HDL. And if you take the clinical history from the patient very carefully, his diet, the fad is now that they eat a lot of nuts. They have children who send them those type of foods from abroad. So all the time they're eating those nuts. And when they live actually on nuts, the elderly people, they are tending to have very high cholesterol, HDL cholesterol. So taking the diet of the individual into consideration when you interpret these high values is absolutely essential. We do see nowadays high levels of HDL.
We were also seeing this high HDL in when we were doing that precipitation method for extraction of HDL, and diagnostic sensitivity of such methods are very poor in limited resource setup when they do. Sir, I have a question that what is the, I mean, can you elaborate on the role of LPPLA2, which has been in a dilemma, or it's not being practiced in that level in
This is also
clinical
just
setting?
as this will also come up as a potential marker only. It is not routinely used in practice. Now, the advantage over high sensitivity CRP, as I mentioned, it is more specific, whereas CRP or HSCRP can be a this particular marker is more specific for the coronary vessels, the inflammation of the coronary vessels. So it is considered to be more specific for cardiac conditions. But otherwise, it's also a risk marker only, but yet to be introduced in clinical practice. Maybe potential marker for.
So these were the questions in the chat box. The forum is open for questions. If any of you have any question. One more question that is raised now. NT-proBNP is inactive product, so why it is used for risk? N-terminal proBNP.
It's a marker. That's all. It's not. It's used as a marker. Even though it's an inactive product, it's coming from the proBNP, and the presence of NT-proBNP essentially indicates that the activation cascade has taken place. So even though it's an inactive thing, it's used as a marker for the activation of BNP. Is that clear?
Hope that is clear to Hiral Arora. So the forum is open for question. If anybody want to raise question, you can unmute and ask question.
Dr. Aparna was saying she had a question.
Yeah, yes.
Yeah. So I think
Dr. Aparna?
yes. So I have a question which is commonly seen in a small lab, not big labs which are doing the direct LDL. Pardon, because this is a very basic question, but how long what's the correlation of calculated versus direct LDL? This is a question which many times we are seeing when we meet the clinicians. And number two is we would like you to elaborate maybe on the LPA, because there are many labs who are doing LPA by various methods. So in that, which is the gold standard? These are two questions.
Dr. Rajiv, would you like to answer that question? You're doing that. You're seeing that regularly. I know that.
I'm not very sure, sir.
Okay, then
So,
actually there can be differences between calculated LDL as well as measured LDL. This can be due to various reasons, as we know now. The calculated LDL is essentially based on the Friedewald's formula, which has lots of limitations, including the calculation assumptions of triglyceride being normal, etc. The basic concepts, many concepts of lipid metabolism have been taken for granted for calculation of this LDL cholesterol. But however, when we are actually measuring it, obviously we tend to get a difference. Now, this is expected. Maybe in the initial years when the LDL assay was started, this was probably taken as a question regarding whether the assay is correct. The soundness of the assay, etc., were doubted during the initial years. But afterwards, it was people realized that these are due to the limitations of the Friedewald's formula. So essentially, I think most of the labs now prefer estimating LDL rather than calculating LDL. That's what I understand. I don't know.
Just one more comment on that calculated LDL. So there are many more calculations that have come up because of the fallacies that the initial Friedewalds had. But even then, a direct measurement is still much better, as Dr. Kannan has just mentioned. Just to emphasize that.
Yes, ma'am. I was also trying to comment on that because I had a study using a large population on the calculated LDL that is that can be done for even for non-fasting samples. So it is true that these calculations that are available now based on the large population studies derived based on the large population studies, even though they are maybe applicable for 50% of the case or 60% of the case, it's not true for all the conversions that we do. So it is not exactly when you calculate the LDL value or measure the LDL value, that may not represent the calculated value, or the correlation is not true for all the studies I made. But that will give you an idea, that will give you a picture when it is calculated. May not be 100% accurate. The accuracy will be different and maybe based on other factors also.
Is more sensitive, more accurate.
Yeah, thank you so much.
And Dr. Kannan, about the LPA, Dr. Aparna's question on LPA, please do go ahead with that.
LPA, what was the exact question?
So which is the gold standard method? Because there is a lot of variation when I see various labs and their reports coming to us. So which one out of your experience do you think is very sturdy or a gold standard method?
I'm not sure about that, to be very honest. Anybody else can comment?
The immunoturbidimetric assays do give quite good results, but the problem with LPA is it is usually not used in clinical discretion or in medications, as we know. So at once upon a time, maybe in the late 90s and all, it was quite a big thing to do LPA. But of late, I think nobody really uses it as a method to treat a patient or look at a cardiovascular disease from an LPA point of view. So the requests are also few, but the immunotherapeutic metric platforms give quite good result. Naturally, the reference ranges will be different for difference, but they do give good reports. Even the ELISA methods of yesteryears did give good reports, but I don't think anybody does ELISA methodology now.
No. So Dr.
Thank you.
Shanti, immunoturbidimetry is absolutely, you're right. That is the method used these days and is quite sensitive. And what you're absolutely right about this also, that it is not used in clinical decision making or,
Yes.
prognostication or management, but it is used in prognostication, and it is used as a baseline marker for risk evaluation, especially in Indians. This is a study that our cardiologists are doing. So I just wanted to update you on that.
Okay.
Kannan, we are now moving on to the next section from Dr. Rajiv B. Sharma. I have the honor to introduce him. He is the HOD of Cardiology of Department, Cardinal Gracious Hospital, Vasai currently. And he has completed his MBBS, MD, and DM Cardiology. And he's a member and international associate of American College of Cardiology, USA, and member of the SCI USA. He has completed his cardiology course from prestigious GS Medical College and KM Hospital, Mumbai. He is not only the topper for MBBS, but also the topper for university topper gold medalist for the DM course in the first attempt itself. He practices clinical cardiology, basic and advanced echocardiography, including stress and contrast echocardiography, pediatric echocardiography, ECG stress testing, Holter, and ambulatory BP monitoring. He has experience in various cardiac interventions, including coronary angiography, coronary angioplasty, balloon cardiac interventions, including balloon mitral valvuloplasty, percutaneous device closure for congenital cardiac shunt lesions, as well as single and dual chamber pacemaker implantation. He has special interest in transradial procedure, and also in coronary interventions in heart. Reports, posters, review articles, and he has contributed to chapters in textbooks also. He has been actively involved in research program and in teaching program at university level. Currently, he is working as HOD of cardiology at Cardinal Gracious Hospital, Vasai, and Transition Diagnostic Avigna Heart Center and Pathology at Borivali, West Mumbai. We welcome you, sir, and over to you, sir.
I thank you for the kind introduction, and my apologies for not being on time, and just a tsunami of heart attack patients. And I'll be brief and short in my talk so that we have a time to discuss, and I will be speaking purely on the clinical perspective, because if you ask me biochemistry, I'm a big zero in biochemistry now. So the methodology of testing and those 99 percentile values and upper limit of normal and those area under curves and things are now very far from me. So I'll be speaking purely on how I use cardiac markers in my practice. I'm sharing the content. Yeah. So see, I'll be speaking on the clinical perspective of cardiac biomarkers. Now, how we use it in our practice. Now, what is a myocardial infarction? So myocardial infarction is a clinical event in the setting of myocardial ischemia where there is evidence of myocardial injury. So two things are very important to label a patient as MI. That is, there has to be ischemia. So there has to be an atherothrombotic event in one of the coronary arteries. Along with that, there has to be a documented injury. So how do we document injury? By use of cardiac enzymes. So cardiac enzymes includes our good old days. We were doing SGOT, LDH. We were using markers like CPK total, then came CPK MB, then came troponin I, then came highly sensitive troponins, and then there are other molecules, markers which are coming up on the horizon. But none of them has been as good as troponins. So two things are important. First is ischemia. So the coronary should have atherothrombosis. And second is injury. Now there can be mutually exclusive events. For example, there can be ischemia without injury. What do you call that? Unstable angina. There can be injury without ischemia. For example, a patient of myocarditis, patient of pulmonary embolism, where the strain on the right heart leaks those cardiac enzymes, but there is no ischemia per se. So ischemia, injury are mutually exclusive events. When they happen together, which is the most common scenario in our clinical practice, we call it as myocardial infarction. So how do you label myocardial infarction? So it is seen when we document a rise or fall in troponin along with first symptoms, second ECG changes, and third is imaging evidence of new loss of viable myocardium or new regional wall motion abnormality on the echo. So this is the classification of acute coronary syndrome. Acute coronary syndrome is of three types. One is ST elevation MI. So for an ST elevation MI on ECG, the artery has to be totally or almost totally occluded. So ST elevation MI means that the atherothrombotic event in the coronary is total occlusion or a near total occlusion. Whereas if it's a subtotal occlusion, there are two subsets. One is unstable angina and the second subset is non-ST elevation MI. So in unstable angina, there is no injury. There is ischemia, but there is no elevation in cardiac enzymes. And in non-ST elevation MI, there is ischemia along with the rise in cardiac enzymes, but it's a subtotal occlusion. Now, what are the types of MI? Now, this is, I think, too academic. Type 1 MI is caused by atherothrombosis. Type 2 MI is caused by demand-supply mismatch. So, for example, a patient with atrial fibrillation, patient with inappropriate sinus tachycardia, patient who is recovering from COVID, patient who has a coronary vasospastic angina, patient who has a shower of emboli from a paradoxical PFO, for example, or a patient with microvascular dysfunction. Only 5 to 10% of the coronary flow is macrovascular. The remaining complex interplay of 90% blood supply is due to the microvasculature. Unfortunately, the methods used to evaluate microvasculature are only academically pursued, and we cannot practically measure them in clinical practice. But microvasculature also forms an equally important group of patients with type 2 MI. Type 3 MI is a patient with presentation of ischemia, infarct, but he dies before we can draw a blood sample to document injury. So there is symptom, chest discomfort hua and the patient raat ko neend mein chala gaya before we could draw a sample. So that will be type 3 MI. Type 4A is MI in the setting of angioplasty. So patient who's undergone an angioplasty. And how do we label such patients as MI? So it depends on the baseline value of the troponin. So if the baseline troponin was normal, a rise in troponin of 5 times is diagnostic for MI after angioplasty. If the baseline troponin was elevated, then 10 times elevation compared to the baseline troponin is the criteria for MI post angioplasty. Type 5 MI is MI post bypass surgery, where the criteria is even more vigorous, because bypass surgery itself, when you're putting the patient on heart-lung machine, there is a lot of myocardial necrosis, myocardial apoptosis, there is transmigration of the troponin molecules in the blood. So 20 times elevation is considered diagnostic for a post-CABG MI. I don't know where my... So I'll just be discussing about troponin in a little more detail. So troponins are of two types that we measure in the blood. There are 3 types of troponin. Troponin T, I, and C, that was in the excitation contraction coupling we studied in physiology. And out of which, for our practical discussion in cardiology, we use trop T and trop I. Trop T has a little shorter half-life compared to trop I. So we use more of quantitative trop I. There are qualitative ways and quantitative ways. Qualitative requires a particular threshold. They are those non-HSCRP old generation assays, whereas qualitative exactly tells us in nanogram per ml, nanogram per L values and there is a standard cutoff. For example, in my hospital, we are using Allier. Allier is now acquired by Abbott Laboratories, and we get a report like so we get a report which which I don't think my screen is, my photograph is visible. Okay. So we get a report where CPK-MB along with troponin and BNP are simultaneously released in a POC machine, and the report is available to us within 20 minutes. So that is what I use in my setup, and it measures quantitative levels of highly sensitive troponins. Now, is elevated troponin a gospel truth for MI? No, as we discussed earlier, there can be elevation, there can be myocardial injury without ischemia. For example, in myocarditis, in aortic dissection, in pulmonary embolism, in patients with vasospastic angina, in patients with sepsis, systemic inflammatory response syndrome, in patients with renal injury, where excretion of troponins is hampered. They have a baseline chronic elevation of troponins. Old age also, there is a marginal troponin elevation seen. So we have to see the clinical context. So history is the most important. After history comes the ECG. And then comes the cardiac enzymes. So this is how we approach a patient of chest pain. So any chest pain comes to us, we evaluate the history. History tells us, gives us a clue whether the chest pain characteristic is typical or atypical. If it's a typical chest pain, then we, of course, do an ECG within 10 minutes of the casualty visit. If within the 10 minutes, the ECG is suggestive of ST elevation, ST depression, or there are Q waves in the ECG, then we send the patient's cardiac enzymes. So cardiac enzymes come negative. Can you send the patient home? No, because it could still be unstable angina. Cardiac enzymes come positive. How does it help you, doctor? It helps me in deciding on early revascularization strategy. So rather than waiting for up to 12 hours, kal subah dekh lenge, we decide that if the patient is hemodynamically unstable, electrically unstable, or has ongoing angina, then we take up the patient in the cath lab on a priority basis. So that is the value of cardiac enzymes for us in clinical practice. Along with that, we also parallelly do echocardiography, and then we do an angiography where we show the atherothrombi and we treat it along with parallelly helping the patient's prognosis become better. Now, when we are using troponin to diagnose acute MI, we should keep three things in mind. With highly sensitive troponin assays, most patients can be diagnosed within 2 to 3 hours of presentation. So previously, when I started practicing in 2006, what we would do is chest pain comes to us. We do cardiac enzymes. If cardiac enzymes and serial ECGs, if cardiac enzymes are negative, we repeat cardiac enzymes after 12 hours. If the ECG has subtle variation and the troponins are negative on 2 occasions, then you do a pre-discharge treadmill test. If the treadmill test is okay, then the patient is fit to go home. Now with the highly sensitive troponin assays, the 5th generation assays are easily available now. We do a patient's sampling at arrival. If the ECG is non-diagnostic, we do the cardiac enzymes. Cardiac enzymes are negative. We ask the patient to be in the casualty. We don't admit the patient. The patient stays in the casualty for 3 hours to 6 hours. We do repeat cardiac enzymes. If the repeat cardiac enzymes are negative, we can almost certainly say that patient does not have MI. Also, at the same time, you can rule out the other factors like pulmonary embolism, aortic dissection, Boerhaave syndrome, esophageal rupture, acute peptic ulcer. So these are the threatening things in casualty department to pick up in a patient of chest pain. So if the troponin is negative at presentation, which happens in the first 2 to 3 hours of MI, because troponin is highly sensitive, troponin is also detectable after a certain time limit of 2 to 3 hours, then you repeat serial troponin at 3 to 6 hours. And at 6 hours, if it is negative, almost conclusive, you can say that there is no myocardial injury. Along with that, if the ECG is not showing any changes, so there is no myocardial ischemia. So no ischemia, no injury, MI is safely ruled out at hour 6. So it's very important because nowadays 1 day of hospitalization in patients bill becomes 30 to 50,000 rupees. So when you can, this is called as a triage situation in the emergency ward. For example, today I have done 8 procedures since morning, including 3 complex angioplasties. So a patient of chest pain comes when my cath lab is busy, and we have to risk stratify which patient to take up in the lab first. So this is how we use cardiac enzymes to our benefit. Now, what are the causes of elevated troponin? Sorry, yeah. So there are multiple causes. First cause is myocardial ischemia, which can be ACS, STEMI, non-ST elevation MI. Other coronary ischemia can happen due to atrial arrhythmias, ventricular arrhythmias. Now, what arrhythmias do is tachyarrhythmias occur at the cost of diastole, coronary fill-in diastole. So whenever you have tachycardia, there is diastolic duration shortening. So the coronary ischemia does happen, but it is not due to atherothrombi. So it is labeled as other coronary ischemia. Patients with cocaine causes intense vasospasm. And we do see them in our practice. It's not that cocaine sirf Shah Rukh Khan ka beta leta hai. It is available in schools, high-end schools of every nook and corner of Mumbai. Coronary intervention, post-coronary intervention, which we cause transient ischemia with the balloon dilatation and the stenting, coronary vasospasm, static coronary atherosclerosis. For example, a patient with 80% stenosis, and now the patient is taken up for a surgery and there is hypotension. So BP of 130 may still be adequate to perfuse that 80% stenotic area. But if the patient has a BP of 100 during the surgery, that 80% plaque will give ischemic trouble. So fixed coronary ischemia, severe hypertension. Hypertension causes increased myocardial O2 demand. So accelerated hypertension, they land up with pulmonary edema and elevated troponins. Coronary embolus, so sometimes some rheumatic heart disease, mitral stenosis, LA clots, they come to the LV and they may rarely go into the coronary. We had one such live thing happening. I was presenting live to an audience, and this happened live when I was doing a balloon mitral valvuloplasty. And I had to treat the coronary first and then do the balloon mitral valvuloplasty. It's a rare occurrence, but because we do a transesophageal echo before every balloon mitral, but still it can rarely happen. Aortic dissection, coronary vasculitis. In Kawasaki disease of the kids, there can be elevated troponin. So non-coronary ischemia, shock causes shock everywhere. So kidneys are shocked, the liver is shocked, the brain is shocked, the patients are delirious, the heart is shocked, and the cardiac enzymes show elevation. Then we have hypoxia, we have hypoperfusion. So distributive shocks of cardiac tamponade, pneumothorax, pulmonary emboli, global ischemia, and cardiothoracic injury, blunt trauma to the chest can elevate cardiac enzymes. So the other causes are renal failure, sepsis, almost universally sepsis and COVID did elevate cardiac troponins, and patients with elevated troponins had a worse outcomes. ARDS, stroke, subarachnoid hemorrhage. Now you will say brain में injury हो रहा है, why should troponins get elevated? आप बोल रहे हैं stroke में cardiac enzymes get elevated. So it happens due to dysautonomia. So autonomic dysfunction causes excessive sympathetic discharge at the myocardial level, and that is how subarachnoid hemorrhage and stroke elevate cardiac troponins. Extreme exertion, athletes, elite athletes, cardiac contusions, burns, anthracyclines, which are chemotherapeutic agents, cause a lot of cardiotoxicity, electric shocks, carbon monoxide poisoning. Stress cardiomyopathy, we see this quite not so uncommonly. Stress cardiomyopathy is where presentation is exactly like an MI. So usually seen more in women. They come to us after a stressor, death of husband, death of mother, death of father, sick child not getting admission in MBBS. So those mothers who are extremely anxious and stressed suddenly have this discomfort in the chest. The ECG shows changes, the cardiac enzymes show elevation. And when we do an angiography is absolutely normal. Echocardiogram also shows a typical ballooning out of the heart's distal apical wall. and the septum. So it resembles an earthen pot in Japan, which is asymmetrical. So it is called as Takotsubo, Japanese pot cardiomyopathy. So we have to remember this as entity as an elevated troponin cause, along with ECG changes, along with chest discomfort with a normal angiogram. We call them MINOCA, myocardial infarct with normal coronary arteries, myocarditis, myopericarditis, rhabdomyolysis, hypertrophic cardiomyopathy, peripartum cardiomyopathy, heart failure. So LV dysfunction of any cause, alcoholic cardiomyopathy, beriberi cardiomyopathy, thyroid cardiomyopathy, ischemic cardiomyopathy, any cause of cardiomyopathy can elevate cardiac troponins. So when do we measure troponin? First presentation. If it's not elevated, we repeat 3 to 6 hours later. And we also do serial ECGs and clinical examination. If at 6 hours enzymes are negative, ECGs show no dynamic changes, the patient is symptom-free, peripheral pulses are well felt, there is no undue tachycardia. So effectively, we have ruled out the 3 major killers: acute myocardial infarction, acute pulmonary embolism, acute aortic dissection. And if the patient is presenting too early, and if you still have doubt, better to admit, observe for 28 hours, 12 to 24 hours, do a pre-discharge treadmill cardiac consult, and then send the patient home. Now, false positive troponins can be seen in infectious mononucleosis where heterophile antibodies can trouble. Skeletal muscle rhabdomyolysis can elevate troponins falsely. Biotin is the way, I think, with which the measurements of troponin are done. Biotin sample and hemolysis can interfere. Anti-troponin antibodies can trouble the patient. I'll just have a brief word about BNP levels. Now, BNP is more of a marker of heart failure, diagnosis, as well as prognosis. They reflect myocardial strain. So strain we pick up on ECG, echo. Echo has specific measurements of strain. And in the cardiac enzymes at the biochemistry level, we have BNP levels, which help us in diagnosing strain of the LV. A BNP elevation also not only helps us in diagnosis, it helps us in prognosis. So suppose an acute myocardial infarction comes to me, I do BNP along with troponin. If BNP normal, only troponin elevated, the mortality on a whole is 2% in 100 patients. Of course, it depends on the clinical presentation. Cardiogenic shock has a 50 to 70% mortality. But if we take an average, when BNP is elevated along with troponins, the mortality is 6 times higher and the death rate is more than 10% in MI. So simple biochemistry value of a BNP elevation along with troponin elevation can help us prognosticate the patient and counsel the relatives better. I'm sorry, actually I shared the presentation from my internet, but other slides are not visible. Hello? Yeah, I'll be happy to discuss any clinical perspective that professors and experts sitting in the panel would like to discuss.
There are 2 questions raised in the chat box from Mr. Mohammed.
Yeah.
Can we differentiate non-STEMI and STEMI by any particular cardiac biomarkers in casualty in early presentation?
So the definitions of STEMI and non-STEMI are on the basis of ECG. So if there is ST elevation on ECG, which should be more than 0.1 millimeter J point elevation except lead V2 and V3 in 2 consecutive leads, then it is ST elevation. If there is ST depression of 0.5 millimeters in 2 consecutive areas, then it is called as non-ST elevation. So it is the ECG change, not the biochemical marker.
So you basically is asking whether any biomarker correlating with that is there or not. We don't have. No? We don't.
No.
And we also continue to ask that why there is high NT-proBNP since COVID pandemic. Any insight on that? Yeah.
So what I was working all through the COVID and doing emergency PCIs and routine cardiology work also for the COVID patients. So what we realized is that COVID has a lot of issues. First, there is microthrombi everywhere in the pulmonary vasculature. Second, not only microthrombi, it was also causing frank pulmonary thrombi, pulmonary embolism. Thirdly, the damage to the lung was at a very significant extent in some of the patients. A lot of fibrosis was seen. Now, what happens in a interstitial lung disease or a disease of COVID pattern where there's a lot of fibrosis is there is strain on the right heart. So 3 causes of strain on the right heart. One was pulmonary microthrombi, second was pulmonary thrombi, macro, and third was lung damage secondary to COVID. This was how COVID was affecting the lung, and this is how lung was affecting the right heart. What we also did see rarely is I had 3 patients of COVID myocarditis. So we did see COVID causing myocarditis, and myocarditis is the reason for LV dysfunction, systolic, diastolic, both, and dysfunction is leading to elevated BNP. Third thing what I did observe in coronary was there were thrombotic events in the coronary. So COVID causing acute myocardial infarction. And that was the reason for elevation in some patients. Also, what we did see with COVID was patients having not only myocarditis, there was some sort of a subclinical myocardial strain. So diastolic dysfunction, differences in the excitation contraction coupling, microvascular damage. So not only did it cause acute MIs, macro, it did cause microvascular damage also to certain extent. So COVID was nasty for us, and COVID also caused a lot of arrhythmias. You will still see patients who have recovered from COVID have a lot of sinus tachycardia. And I did discuss that arrhythmias happen at the cost of diastole and coronaries get underfilled. So that is another reason why there were elevations of cardiac enzymes, troponin and BNP in COVID patients. And they affected prognosis. If there was elevation in troponin, mortality in COVID was almost 2 to 3 times higher compared to an elevation.
Hope that is clear. And one of the other questions that has been raised is it possible patient with the MI can be without tropi elevation?
Yeah. So see, if the patient comes within first 3 hours of presentation, troponins can be negative. So it depends on the assay used. Now, some so-called really peripheral centers, they use some first generation assay, or they're using the stick and those card tests, which I don't know. It is obsolete practice. What simply we can do is this kind of a POC earlier. Now see, this is my patient. I just finished an angioplasty for. You can see the patient had chest pain in the morning at 6 o'clock today. And they ran to 3 hospitals. So they went to one hospital, then they went to another hospital, then they came to my hospital. They were also planning to run away from my hospital before she collapsed. So this is how my earlier, of course, we knew the symptoms of chest pain. That is the first thing we see. Second, we saw the ECG. ECG had ST elevation. So we already knew we are dealing with an MI, and this takes 20 minutes. So 20 minutes can be life and death for our patients. So we do an echo the moment patient comes to us. So echo did show that the LED territory is akinetic, and then we got this report simultaneously. My main purpose of doing this report, to be absolutely honest with you, is showing to the relatives that, see, this is a massive heart attack. So here the troponin is more than 80 for a range of 0.02 nanogram in this patient per ml, and the CPKMB is troponin is more than 10, so 500 times elevation, and BNP is normal. So BNP normal is quite reassuring to me that yes, the mortality, if as she was not in shock, the mortality will be between 2% to 3%. So counseling is better. So this is what we do. So troponin is negative in ST elevation MI happens only when the patient comes within the first 3 hours. Otherwise, ST elevation MI, which happens due to total occlusion of an artery, invariably is going to elevate the troponin. So those theoretical things like obese have less troponin elevation, women have less troponin elevation, that will not adhere to an MI. MI is a major event. So, and non-ST elevation MI, also, do we differentiate from unstable angina on the basis of elevation? So if no elevation, unstable angina. If elevation, non-ST elevation MI. So if elevation, take the patient early to the cath lab. If no elevations, you may wait if the patient is hemodynamically stable. So basically it tells us how urgently we should take the patient in the cath lab. History plus ECG plus clinical examination plus echo plus cardiac enzymes is the 5th marker.
And he continues to ask whether, among TROP-T and TROP-I, which is better?
Yeah. See, sir, troponin T elevates for a short time compared to a trop I. Practically, what we see is 7 to 10 days is the duration for which trop T is elevated and comes down, and trop I remains there for up to 14 days. Practically, also in renal injury patients, trop T is a little more elevated at the baseline compared to trop I. So renal CKD patients, both troponins you will almost always universally find elevated, and we diagnosed it. We diagnose an MI in a CKD patient with a delta rise of more than 50% in the troponin level compared to the baseline. So we do a baseline level, we do after 3 hours, and if there is a 50% delta rise, then we label it as MI. So in CKD patients also TROPA has a little more advantage. Baki in hemolysis and those cross-reacting antibodies, both TROP-T like rhabdomyolysis, TROP-T is affected more compared to TROP-I, whereas in those infectious mononucleosis heterophile antibodies, TROP-I is affected. So my choice of marker, basically because my hospital has been using this and I have 9 years of experience of using this machine. Earlier Abbott's, now Abbott point of care, I am comfortable with TROP-I more than TROP-T.
Can I ask one question, please, sir?
Sure, sure,
sure,
madam.
Yeah. Sir, I come from Care Hospital in Hyderabad, which you know is a tertiary cardiac center. During
State
the
of the
COVID,
art.
yeah, during the COVID pandemic, sir, when we used to do the MIs, we did get numericals which were very high and which we never saw before. And slowly after the time went on and the pandemic was progressing, we started seeing D-dimers being asked for. Post-COVID, when they come for admissions, have you seen any correlation with the numericals of the troponin, which are relatively high, and the D-dimers?
Okay. So, madam, basically, you are asking me that in COVID patients, is there a correlation between TROP and D-dimer?
Yes.
Yes. So, they are independent prognostic markers, but they do have an association because elevated D-dimer will suggest that microthrombi in the pulmonary vasculature is happening at a very massive scale. So, the higher the D-dimer, more is the microthrombosis, and macro, of course, macro may be there if a VP scan or a CTPA confirms it. And that will definitely put strain on the right heart and elevate troponins in a proportionate level. So they do have an association, but independently also they are equally prognostic markers.
Okay. So we are seeing very high numericals, which we have never seen in our lifetime of practice for 25 or 30 years in the lab. So sometimes to release these reports, we have to think twice, then we go into dilutions. And if we say more than 20,000, more than 25,000, I really don't know how these numericals relate to a clinician.
Yeah. So, madam, basically in troponins, I can tell you for sure, the larger the worse the MI, because it is an indirect, it is a definite indication of the myocardial necrosis happening. So if you are having a numerically higher value in the plasma, definitely it means that the patient has a more myocardial necrosis, worse LV function, worse prognosis, large area of infarct on cardiac MRI PET scan, and a very worse outcome. About the D-dimer, madam, I am really not sure whether there is a linear correlation. Although intuitively, it relates that the higher the D-dimer value, the patient will be having more microthrombi and pulmonary, but I am not really aware of any study where the linearity of D-dimer values. What we were doing is, if D-dimers are above 2000, we were at the COVID time, we were asking for a CT pulmonary angiogram, because macrothrombi have to be treated as the pulmonary embolism proper, where we are going fondaparinux dose of 7.5 compared to a fondaparinux dose of 2.5 in a microthrombi. So 2000 was our D-dimer cutoff for doing a CTPA at the COVID times. Above that numerical value, whether it is prognostically correlating, I am not really sure.
Okay, sir. Thank you, sir.
Sure.
So, Dr. Raju, any questions?
I'm sorry. There are a few more questions. And among the TROPI, the question is that whether quantitative or qualitative is more reliable.
Quantitative, no doubt about it, because quantitative assays have more sensitivity, I believe. I mean, qualitative, I have seen a lot of MIs where those lines are not seen. It is like urine pregnancy test. Now, the faint levels of elevation, definitely that line will not stain. So why to risk? Now, see, this is another patient. I did a last primary angioplasty today. Now, this was a patient where BNP is elevated along with troponin. So troponin elevation is not great. BNP is elevated, and the patient's LV function was only 25%. So he had double vessel disease, and BNP, just to give you an example of how BNP elevation in an acute MI situation helped counseling the patients better. See, now it is all about medical legal counseling. Kaun marega, kaun bachega, they are just after our head. Despite being in cardiology for 12 years, and having a good volume, patients are doubting Thomas's. So biochemistry and pathology are our backbone, so we show them this. You take it anywhere in this world and it is a massive MI, they are quiet, If we report the ECG, they don't trust us. Doubting Thomas's patients have become. So prognosticating very important, and diagnosing also, and counseling also. These cardiac enzymes are of great value to us.
Sir, there is some question that why is myoglobin is not a better marker in MI?
Yeah, sure. Sir, myoglobin is non-specific, although it is one of the earliest markers to rise. It can also be seen in a lot of skeletal muscle issues like marathon runners coming with MI, or a patient with a physical exertion, or a patient with a skeletal muscle trauma in a road traffic accident. Myoglobins will rise without being specific for the heart. So what has happened with these highly sensitive troponins is we get elevations as early as 3 hours. So why do you want myoglobin? Previously, those troponin first generation assays and those old markers, they were elevating after 6-8 hours. That theoretical graph that we had all read in Robbins is no longer applicable because of these beautiful highly sensitive troponins. Everything comes at a cost. So highly sensitive troponins improve sensitivity, but at a big cost of specificity. So you can't take a patient with elevated troponins in the cath lab. You can't label them as MI. They can be myocardial injury, but not MI. The injury could be due to anything, tachycardia as well, atrial fibrillation. So sensitivity, yes, it helps in ruling out, but ruling in, we need a lot of information about this. So you need history, you need clinical examination, you need echo, you need ECG, you need angiogram. So all these things are needed.
Sir, apart from this, there is a recent trend in using non-fasting lipid profile. Can you comment on this? Yeah.
So, sir, basically, fasting versus non-fasting differs only in triglyceride and this calculated equations, triglyceride divided by 5 into Friedewald's equation. So, non-fasting is, we are hardly fasting. Intermittent fasting is not, it's a fad rather than a norm. In our country, we are mostly in the post-prandial state. So it is a more robust LDL level that we get from the non-fasting level. And LDL is our first prognostic marker. So if you ask me, Dr. Sharma, if you want one report in lipid profile, it will be LDL, sir. Because targets for LDL are very robust in Indian population. We are at a 2.2 times higher risk than Caucasians. South Asian ethnicity is the worst ethnicity for atherothrombotic events. We are experiencing a tsunami of MI patients. So my LDL targets are very rigid. I mean, Lipid Association of India, we are born with an LDL of 30. We try to be as close to 30 as possible after an MI. If you ask me what is the second marker you will use, that will be non-HDL. So non-HDL will be total minus HDL. So that is also fairly acceptable in a non-fasting state. So basically, most of the times we are in a non-fasting state. So non-fasting correlates much better in my opinion, and it is also incorporated in guidelines. Triglycerides, yes. If you have a triglyceride issue, you may do a fasting state sample. But frankly, even by lowering triglycerides, hard endpoints other than pancreatitis have not been reduced. So Dr. Sharma, will you reduce MI by reducing triglycerides? There is no robust data. It is controversial. Although we say that ideal triglyceride less than 150. So my first target is LDL, second target is non-HDL, third target is lipoprotein small a. Lipoprotein small a is coming up in a big way. And lipoprotein small a measurement assays also have a lot of controversies. I think biochemistry professors can comment better. And level less than 30 is ideal. And if we have elevated lipoprotein small a, there are molecules like PCSK9 inhibitors to lower lipoprotein small a. Or what we simply do is, PCSK9 are very costly, 36,000 rupees per month expense. So what we do is we have a more stricter LDL target. So suppose I give you an LDL target of 55. If lipoprotein small is elevated, I'll give an LDL target of 40 to you. So that is how we approach dyslipidemia in my practice.
Sir, in continuation to what you have already mentioned, I think is one of the question from Dr. Satya is that, can the CKD patient wait for the delta rise in troponin I before you start your treatment?
We never wait. Yeah, we never wait. A symptomatic patient with ECG changes, we don't even look at the cardiac enzymes. You may be surprised that I have not even seen cardiac enzymes in so many of our patients, because we rely on symptoms. Second, we see the clinical examination. So hemodynamic, BP ज़्यादा है, BP कम है, tachycardia है, hypotension है, bradycardia है. Those patients we are going to take up in the lab urgently. Then we are going to do the ECG. ECG tells us a lot of story. So ST depression in more than 8 leads, ST elevation in AVR, V1. I just did a case with ST elevation in AVR. So that was left main disease. So that tells us a lot of story. Then cardiac enzymes. So echocardiography and then cardiac enzymes. So our order is very clear. First is symptoms. Second is examination. Third is ECG. Fourth is echocardiography. Fifth is cardiac enzymes. And sixth is angiogram. So we never wait if the patient is symptomatic.
Thank you, sir. To the audience, if there is any more questions left, you may please type it in the chat box. Else we'll hand over to Dr. Seema or Dr. Aparna.
Yeah. So thank you, Doctor. I mean, both the talks, including our comments, were really excellent and learning. I mean, we really would like to thank Dr. Riju for getting us introduced to Dr. Kannan, and Dr. Avni for getting Dr. Rajiv on board for KAHO for such a wonderful session. Dr. Seema and obviously Dr. Dipti. So we look forward to many such sessions from you, sir. Thank you so much. And there was a feedback form in the board. We request all of you to give your comments. The delegates, definitely. I would like to thank the KAHO team.